This is the workshop for Level 4, Test 4, on kidney and liver. This is Megan Bailey with the New Initiative Program, and I was going to start with a review of the anatomy and physiology of our kidneys. So, in order to understand what's happening in a disorder like acute kidney injury or chronic kidney disease, it's important to understand the functions of the kidneys. The kidneys are responsible for balancing solute and water transport. When we talk about solute and water, solute, we're talking about electrolytes. Those ions that are in our body that are necessary in cellular functioning, like sodium, potassium, chloride, magnesium, calcium, and phosphate. So these are all ions that our body is responsible for balancing, and our kidneys perform that function. So all of the fluid and electrolyte disorders that we've learned about every semester, this is the organ that is responsible for telling which solute goes where, not only in terms of the fluid compartments, so extracellular fluid compartments, including intravascular, interstitial, and transcellular, but also intracellular fluid. That's within our body. And then in terms of the kidneys, our kidneys conserve or excrete solutes and water by either sending it through the filtrate, which is essentially pre-urine, or retaining it, which it would go back into any of these compartments here, depending on the concentration gradient between them. So we're going to be using words like filtrate, retaining, excreting. This means that it leaves the body through the urine. Filtrate is essentially fluid and electrolytes that have been pulled out of the blood to be excreted in the urine. So that's what it means when we talk about moving things into the filtrate. We may talk about retaining something or reabsorbing from the filtrate, meaning it goes back into the blood. So just be familiar with those terms as we move forward. But essentially, your kidneys are essential in balancing all of these nutrients and all of these ions. So they're also responsible for excreting metabolic waste products. Our kidneys have very many functions, and one of them is to excrete something called urea. Now, urea is from digestion of protein. So here's my stomach and my small intestine, my large intestine, obviously not anatomically correct. But what's happening is I'm digesting protein, and breaking down protein in the gut releases something called ammonia. Ammonia filters through the liver, through the portal circulation, where all of these blood vessels from the intestines return through the liver to go back to the heart, that here they're being metabolized. And one example of that is that ammonia is converted to urea, which is excretable by the kidneys. So our kidneys are responsible for excreting urea, but if we have a liver problem, which we'll talk about later, this ammonia is never converted to urea, and the kidneys are unable to excrete it. So keep that in mind when we're talking about excreting metabolic waste products. Also, some metabolic waste products include hydrogen ions. So hydrogen ions, we have to maintain a ratio of 20:1 when it comes to this base called bicarb, or HCO3, and one hydrogen ion. Our kidneys are responsible for excreting a lot of this and retaining a lot of this in comparison, because for every 20 bicarb molecules, we are supposed to have one hydrogen molecule. For every one hydrogen molecule, we are supposed to have 20 bicarb molecules. And all of this is to provide a foundation for you to understand why the body does what it does when the kidneys fail. Another function of your kidneys is conserving nutrients. When our blood is filtered through our kidneys, it's filtered in the nephron, and this is our nephron, and this is our blood vessel. And this is obviously a very simplistic view of it, but this is just to go through this so that you can understand the basics. In our blood, there is glucose, hopefully, as long as we have an adequate dietary intake. So if we have all this glucose in our blood, our kidneys have these little active transport pumps that would basically reabsorb, if any glucose gets into the filtrate, it would reabsorb all the glucose that it could. However, these active transport pumps have a maximum capacity, and that maximum capacity is at 180 milligrams per deciliter. When that much sugar is in your blood, if there's any more, all of this sugar backs up at the pump and it can't keep up with it. So what happens is you see glucose spilled in the urine, which is not a normal finding. So your kidneys are responsible for conserving that glucose. Another nutrient that shouldn't be leaving the blood vessel is albumin. Albumin is a protein, but if there's some sort of damage, glomerular damage, large proteins can leave. And I know this drawing is kind of messy, but bear with me. So your kidneys not only balance solute and oxygen and water transport, excrete metabolic waste products, and conserve nutrients, but like I said, under excreting metabolic waste products, they regulate acids and bases. So for every 20 bicarb molecules, we have to have one hydrogen molecule. There are other implications when it comes to buffering out acids in your body that are related to the kidneys, and we'll get into more detail about that. Now, sometimes we forget the endocrine functions of the kidneys. Some endocrine functions include regulating blood pressure. And this is where I'm going to talk about the RAS system. If you don't have an understanding of the RAS system now, let's get you set up with that. So our body is very, very afraid of not having enough volume and not having enough blood pressure. We are afraid of hemorrhaging, we're afraid of dehydration. Those are common problems that the body is afraid of, essentially. So our kidneys, they release something called renin when our blood volume is low. Some of the reasons or stimuli for releasing renin from the kidneys are decreased blood volume, which is manifested by renal ischemia. Meaning the kidneys are not getting enough blood flow. So the kidneys are freaking out. They're almost, they're not quite dead, but they're just like, please give me some more blood, basically. Another trigger or stimulus for the RAS system is decreased sodium in the blood, because the net result of the RAS system is an expansion of sodium in the blood. It's also expansion of water in the blood. So our stimuli are usually in these negative feedback loops, which is this endocrine function here. And if you're not familiar with those terms, go back and review your A and P. Those end effects or net results of these processes are usually the stimuli, because the whole function of this process is to correct the stimulus. Another stimulus for the RAS system is an increased potassium level. So if our potassium's high, this is going to stimulate the RAS system. One thing that a lot of people aren't familiar with is that the RAS system can also be stimulated by the sympathetic nervous system, so your fight or flight response. So if you're in a situation where you feel as if your life is threatened, your body will take over and start expanding your blood volume, vasoconstricting. That's the net result of the RAS system. Another stimulus are prostaglandins. Prostaglandins are part of the inflammatory process, but they're also elevated when a woman is pregnant. And this is going to come into play when you start to understand. Sorry, that's level 2. I was thinking I was doing level 2 workshop. This is level 4, my bad. So prostaglandins, they're elevated in pregnancy. And so what I was trying to say is that when you have an elevated level of prostaglandins, that helps expand your blood volume because it's starting the RAS system. When women become pregnant, they need a lot more plasma volume and red blood cells to supply to the placenta and the fetus. So an elevation in prostaglandins stimulating the RAS makes sense in pregnancy because it's going to help you expand that blood volume in pregnancy. So yes, you're going to get sick of me saying expanding blood volume and retaining water and retaining sodium, but you won't forget it. So renin, when it's released, our liver is responsible for synthesizing a plasma protein called angiotensinogen. Now, angiotensinogen is a precursor molecule that the liver synthesizes from amino acids taken from the portal circulation in the intestines from breaking down protein. So angiotensinogen is in an inactive form, but when it interacts with renin, it makes it active and becomes angiotensin 1. And these are just terms to describe a change in chemical structure. Your lungs, they release something called angiotensin converting enzyme. Now, angiotensin converting enzyme interacts with angiotensin 1 and converts that to angiotensin 2, and this is when the action really starts to happen. So the first effect that we're going to talk about is potent vasoconstriction. Potent vasoconstriction, that increases vascular tone in the systemic circulation. It's going to increase systemic blood pressure. That's the effect of angiotensin 1. The second effect of angiotensin 2. The second effect of angiotensin 2 is to stimulate the adrenal glands and the adrenal glands are what I call your kidney hats. They're those little glands on top of your kidneys. And that's going to stimulate the adrenal glands to release aldosterone. Now, aldosterone is a mineralocorticoid that's released from the adrenal cortex, and it helps your body retain sodium and water and excrete potassium. So notice decreased blood volume, decreased water in the blood, decreased sodium in the blood We're retaining water and sodium. That's going to increase water and sodium levels. The net result being increased blood volume. It also helps us to excrete potassium. If you notice here, we have increased potassium as a stimulus. So the stimuli are the opposite of the effect. And the net result of the RAS system is to help you perfuse, to increase your blood pressure, increase your blood volume. So if you have any more questions about that, go back to your reading and revisit the RAS system. You can go to your index and find every spot in your med-surg book that's going to tell you how that operates. So it's a pretty big deal for the kidneys. They, like I said, they have multiple essential functions. Another endocrine function of your kidneys. It is going to help with erythrocyte production. Now, the hormone that stimulates erythrocyte production is called erythropoietin. Erythropoietin is going to be stimulated by your kidneys to increase red blood cell production. So keep that in mind when we talk about the anemia associated with kidney failure. Finally, an endocrine function of your kidneys is that it releases this really long hormone called 1,25-dihydroxyvitamin D3. And I'm not going to write that out because that's not something that I want to overwhelm you with, but it is essential in calcium metabolism. It essentially helps activate vitamin D that's absorbed in your gut to a form that your body can use. So it's going to activate vitamin D in order to help reabsorb calcium from the gut. The kidneys also help in something called gluconeogenesis. They synthesize glucose from amino acids. And finally, the most obvious function of the kidneys is the formation of urine through all those terms we talked about. Filtration, reabsorption, and secretion by the glomeruli and tubules. So that's a review of the functions of the kidney, both kidneys. If you have any questions about the A and P behind it, your med-surg book has an in-depth explanation for each of those systems, and there's also a chapter, I believe, on assessment of the urinary system in your med-surg book. So if you need to go over any specific function, go through chapter 44. It starts on page 1015. So if you feel weak on the A and P of the kidneys and the urinary system, because it's not just the kidneys, it's also the ureters, it's the bladder and the urethra, and it's different in terms of the urethra between men and women. So make sure you review that. Let's move to chapter 46 in your med-surg book, starting at page 1069. What I've done is put together a fairly thorough outline that kind of gives you the main points throughout the chapter, and so let me take you through that outline. Let's start with understanding what the term kidney failure means. So kidney failure is the partial or complete impairment of kidney function. So kidney failure is going to have an effect on every single function that we just discussed, that your kidneys are responsible for performing. This results in an inability to excrete waste products and water. So our patients are going to be having a hard time managing the waste products within their body, which have physiologic implications like the problems with urea building up in the body, and the problems with water usually being too present in the body, as we saw in the RAS system. The RAS system is designed with renal ischemia to retain water. So if we have an overactive RAS system, that's when we see that fluid volume overload. However, it's going to vary based on the stage that your patient is going to be in, and that's why we're going to go into depth about each different stage so we can understand what's happening and why. Kidney failure can be divided into two categories. It can be acute, and this is when we talk about acute kidney injury, or abbreviated from here on out, it will be known as AKI. This AKI is characterized by a rapid onset. In contrast, we also have a chronic form called chronic kidney disease, which we will call CKD. Now, chronic kidney disease is usually associated with the development of cardiovascular disease. CV is cardiovascular, CV disease. And it's also associated with diabetes mellitus as well, which is usually in conjunction with atherosclerosis, because we know that glucose, when it's built up in the body, causes inflammation of the endothelium, which promotes lipid deposition and the development of atherosclerosis. So let's get into acute kidney injury in particular. Acute kidney injury, or AKI, is a rapid loss of kidney function accompanied by a rise in serum creatinine and or a reduction in urine output. It has a high mortality rate. It's 70 to 80%. But it is potentially reversible. So as nurses, we have to be vigilant in understanding and noticing the signs and symptoms in your patient. I mentioned that development of a rise in serum creatinine. There are a couple terms for that. So we have the term azotemia. And this term specifically refers to an accumulation of nitrogenous waste products. And I mentioned when we were talking about the functions of the kidneys that we have waste products when it comes to protein metabolism. So when I'm talking about nitrogenous waste products, I'm talking about blood, urea, nitrogen. So remember from the previous slide that protein in the body results in a release of ammonia, which your liver is responsible for processing into urea. And then I said that the kidneys are responsible for excreting this urea. So BUN has to do with protein metabolism, blood, urea, nitrogen. Remember, nitrogen is a building block. It's an essential molecule for the buildup of protein, the chemical makeup of protein. So nitrogen is going to be released when protein's broken down. Ammonia should be converted to urea and eliminated by the kidneys, but if the kidneys are non-functional, that results in this azotemia. So blood urea nitrogen, urea is a byproduct of protein metabolism. Another nitrogenous waste product associated with proteins in our body, which if you think about what part of our body is made up of protein, well, most of it. So creatinine is a result of muscle metabolism. When we're talking about proteins in the body, a lot of the time we're talking about muscles because our muscles are made up of the building blocks of protein. So muscle metabolism results in this nitrogenous waste product called creatinine. That's if we exercise, if we have any sort of muscular trauma, that creatinine is going to change, but it's usually pretty constant, as opposed to blood urea nitrogen, which is associated with protein metabolism. Now, BUN can be elevated for a variety of reasons. Sometimes it's related to the kidneys not being able to get rid of enough urea. Sometimes it's related to an increased dietary protein intake. Sometimes it's also elevated because your patient's dehydrated. So there are a variety of reasons why BUN could be elevated, but there are only a few reasons why creatinine is elevated, and most of the time, because muscle metabolism is so constant, the rise in creatinine reflects kidney problems in AKI. It's the most reliable lab value when it comes to AKI, as opposed to BUN. So make sure you remember that. So we have an increase in serum urea and an increase in serum creatinine. Now, another term you might hear that's used interchangeably but has a slightly different meaning is uremia. This is still an increase in those nitrogenous waste products, BUN and creatinine, but it's characteristically with fatigue, anorexia, nausea and vomiting, itching or pruritus, and neurologic changes. So those are some lab values that you're going to see characterized by that characterize acute kidney injury. In terms of the time frame for AKI, we talked about how it has a rapid onset. So time frame, this can develop over hours to days. And this is going to depend on the cause of the AKI, and we can really divide the causes of AKI into 3 different kinds. We'll talk about which kind as we go through the rest of this chapter. The onset of AKI is marked by a progressive elevation. So in a progressive increase in BUN, creatinine, and potassium. Now, potassium is going to be elevated because when your kidneys are functional, our body excretes 80 to 90% of the potassium in our body. So if our kidneys aren't functioning and we're not able to excrete that potassium, then it's going to build up in our blood and cause signs and symptoms of hyperkalemia. And I will say, due to the extensive nature of this chapter, I'm going to try to hit everything I can, but please, if you aren't familiar with the signs and symptoms of fluid and electrolytes, there is an online workshop under the Nursing Commons on fluid and electrolytes if you need to review that, or chapter 16, I believe, in your MedSurg book has a chapter on fluid and electrolytes. So be sure you can identify those electrolyte changes. Not only do we have a progressive increase in bone creatinine and potassium, but we may or may not have oliguria. So in acute kidney injury, the first phase of the disease is characterized usually by oliguria, but in 50% of cases, that oliguria is not present, and so it would be a little harder to identify and diagnose as a result. And also, urine output changes, those are not directly correlated or directly indicative of glomerular filtration rate. So just because a patient is urinating a lot, like in the diuretic phase of AKI, doesn't mean that they're filtering properly in their kidneys. So your GFR, your glomerular filtration rate, is a lab value determined by a 24-hour urine collection that would tell you about the function of your kidneys. However, that's not always directly correlated to urinary output. So starting on page 1070 in your MedSurg book, let's talk about the etiology and the pathophysiology of acute kidney injury. So, understanding the etiology, the patho, what it looks like in the patient, it's not as straightforward as the heart is, because your kidneys are so intelligent to the point that sometimes it doesn't quite make sense what's going on with them, because the nephrons and the arterioles surrounding them rely on such specific pressure gradients that it doesn't always look the way that it might with a pump that's 4 chambers. Basically, the patho is a little more complicated than other types of diseases. So let's start with the etiology and talk about the different causes. So like I said, it's divided into 3 categories. So we have pre-renal, post-renal, and intrarenal. So if we start with pre-renal, look at page 1070 in your book, and there's a figure 46-1 that shows 3 different anatomical representations of the cardiovascular and neurologic systems. Under the pre-renal, do you see how the heart, the aorta, leading to the kidneys, those are all in color. So pre-renal represents basically the pipes, the prime. It represents factors that can reduce systemic circulation. That results in a reduction in renal blood flow. So if you had a patho map to represent that, we would say reduced systemic circulation, leading to reduction in renal blood flow or renal ischemia, leading to decreased glomerular perfusion, and glomerulus being that structure in the kidney where the nephron and the artery and they kind of coil together, and filtration of the kidneys. So this has to do with all of the anatomical structures supplying blood to the kidneys, whether it's the heart, the blood itself, the arteries. All the things we talked about in shock, any type of shock can lead to AKI. We know that sepsis can lead to MODS. Well, AKI is a type of MODS. AKI is kidney failure as a result of these 3 classifications of causes. In particular, pre-renal has to do with poor tissue perfusion related to impaired cellular metabolism with the definition of shock. There are other things that can contribute to AKI, but all your different types of shock can lead to AKI. So, common causes, which you can see in your book on table 46-2 in page 1070. So some common causes, they could be hypovolemic, your patient. Now, hypovolemia can occur for a variety of reasons. The patient could not be taking in enough water, dehydration, severe dehydration. They could be losing blood, so hemorrhage. We could have excessive GI losses, like diarrhea and vomiting. We could have excessive diuresis, like in diabetes insipidus from test 1. We could also have hypoalbuminemia, and this could result from malnutrition. This could result from burns. This could result from liver problems. There is something called hepatorenal syndrome that we'll talk about in liver failure. So your patient could have a prerenal cause of AKI related to hypovolemia. Another cause of a prerenal AKI is decreased cardiac output. You see in that picture that I referred to earlier, the heart is highlighted as well. So it could also be related to dysrhythmias that you learned about for test 2. Cardiogenic shock. Like I said, any type of shock, this can lead to AKI. Anything that compromise renal perfusion. Heart failure. Myocardial infarction. If your pump's not working, how are your kidneys going to be perfused? Another cause could be decreased peripheral vascular resistance, so that pressure in the tissues that maintains perfusion. These are your distributive shocks. So anaphylaxis. Neurologic injury, like in neurogenic shock, and also septic shock. Another cause, like I said, it's the structures that provide blood flow to the kidney. So if we have decreased renovascular blood flow for any reason, BF is blood flow, we could have clots, so bilateral renal vein thromboses. Embolism to the kidneys. Hepatorenal syndrome that I talked about with liver failure, and we'll get into more detail with that. Renal artery thrombosis. So these are some causes of prerenal acute kidney injury. Prerenal can lead to intrarenal damage, meaning that I don't have enough blood flow to my kidneys. Well, what happens when I have ischemia? That leads to infarction, right? So if I have infarction of kidney tissue, that's intrarenal damage. That's acute tubular necrosis. So prerenal causes can lead to intrarenal damage. Let's talk about what intrarenal looks like, our second classification of acute kidney injury. So intrarenal problems are conditions that cause direct damage to kidney tissue. Resulting in impaired nephron function. So some causes of intrarenal damage, we could have nephrotoxic injury. And remember, these are on that table on page 1070. So nephrotoxic injury, this can be caused by drugs. Some drugs are nephrotoxic, like our aminoglycosides that typically end in mycin, although vancomycin is its own class, so that's not considered an aminoglycoside, but one might be gentamicin or amikacin. Those are some antibiotics that can be nephrotoxic. Another antifungal is amphotericin for your kidneys. And aminoglycosides are amine to your kidneys. Amphotericin B is an antifungal medication that is particularly nephrotoxic. So anytime you're giving your patients these meds, we always want to be checking kidney function. One nephrotoxin that we talk about a lot is contrast media. So if your patient has poor renal function already and they go in to get angiography of any kind, that contrast media is used, and that can crystallize and cause problems in the nephrons. So we need to make sure that if our patients do have pre-existing kidney diseases, that the physician is aware of that, or the practitioner is aware of that, and is taking the appropriate measures like hydrating before and after contrast media infusion if we have to do this angiography. Another cause of nephrotoxic injury is a hemolytic blood transfusion. And this may seem to be coming out of left field, but what happens is when the agglutination occurs in giving the wrong blood type, hemoglobin is released from the red blood cell, and that gets stuck in those tiny nephrons. And so we have problems perfusing the kidneys because hemoglobin in large quantities released that way is nephrotoxic. Severe crush injury. So if we have muscle injury, that releases myoglobin, which essentially does the same thing hemoglobin does. It gets stuck in the kidneys and causes ischemia to the kidneys. And other nephrotoxins, chemical exposures. So it could be to something like ethylene glycol, which is used in antifreeze. It could be lead or arsenic, or something called carbon tetrachloride, which is used in dry cleaning. Any of those chemicals can also cause nephrotoxic injury. Interstitial nephritis is another intrarenal cause, where you have inflammation of that basement membrane. And that can be caused by allergies, whether it's to a medication, like NSAIDs, antibiotics, ACE inhibitors are some examples your book gives, or it could be caused by infection. If it's bacterial, it could be acute pyelonephritis, which you guys learned about in level 3. It could be viral with cytomegalovirus, or fungal with candidiasis, which is a yeast infection essentially. Intrarenal damage is primarily caused by acute tubular necrosis, primarily a result of ischemia, nephrotoxins, or sepsis. So acute tubular necrosis is going to occur with intrarenal damage related to these causes. It could be acute tubular necrosis, or ATN. This could be post-ischemic, which would be what I was talking about before. Intrarenal damage can be caused by prerenal damage, like poor perfusion to the kidneys. So that would be a post-ischemic acute tubular necrosis, or it could be nephrotoxic, like those drugs we were talking about, like the aminoglycosides. Let's see, so this was kind of an aside because I want you guys to understand what is meant when you see the term acute tubular necrosis. It's basically death of those nephron tissues, and we'll talk about what you see in the urine as a result of that. Other causes of intrarenal damage, prolonged prerenal ischemia, like I said. Acute glomerulonephritis. Thrombotic disorders like DIC. Toxemia of pregnancy, so that's that increased blood pressure associated with eclampsia. And then systemic lupus erythematosus. And that is an autoimmune disease that targets specific tissues in the body, and one of the worst tissues that it targets with the worst effects is the kidneys themselves. So that's intrarenal cause. Let's talk about our third and final cause, which could be postrenal. Now, if you look at that figure again on page 1070, you can see under postrenal that the ureters, the bladder, and the urethra are all highlighted. So that's everything. Let me give you a little example. That's everything leading from the kidneys, the pathway out of the renal pelvi, into the bladder, through the urethra. So I'm going to highlight it in yellow. Everything out from the kidneys. The structures leading urine out. So anything that interferes with those structures can cause postrenal damage. Postrenal is essentially caused by a mechanical obstruction in the outflow of urine. Essentially what happens is, let's say we have some sort of obstruction in this ureter here that backs urine up into the renal pelvis, which results in dilation of the kidneys. So one term you want to be familiar with regarding postrenal damage is hydronephrosis. This is essentially kidney dilation due to backup of urine. This is going to result from obstruction. Pushing urine back into the kidneys and causing them to dilate. So what happens here is, as the kidneys become filled with fluid, that increases the hydrostatic pressure in the kidneys. And like I said, we have very specific pressure gradients to maintain in these tiny little nephron tubules. And so if there's any hydrostatic pressure that's disturbing that, that's going to interfere with absorption, filtration, excretion between the nephron and the arterioles. This can be reversed as long as it's relieved within 24 hours of onset. So we want to watch our patient's urinary output. With postrenal damage, if we have an obstruction to the outflow of urine, we may have anuria. And that's the most common finding in terms of urinary output with postrenal problems, is anuria, which is less than 50 mils per day. So if your patient's not peeing at all, we would think, this could be a blockage. Some common causes listed in that table. We have benign prostatic hyperplasia, or BPH, which I'm sure you see in patients' charts all the time. Prostate cancer, renal calculi, any trauma to these structures can cause postrenal damage. If there's trauma to the back, because we know our kidneys are retroperitoneal, meaning they're not in the peritoneal space, they're behind it. So any trauma to the back, any trauma to the pelvis, because that's where that urethra exits, any trauma to the perineum, any to the ureters, any of those structures. If we have any extrarenal tumors in the peritoneal space that start to, or retroperitoneal space that start to compress those structures, bladder cancer can cause post-renal damage, neuromuscular disorders. And we talked about spinal cord injury, something called myasthenia gravis with paralysis of muscles can cause decreased peristalsis in the ureters, and so we don't have that urine flowing very easily downward. Spinal cord disease, spinal cord injury, and then urinary strictures where those tubes narrow. So those are all causes of damage to the kidneys. It could be before the kidneys in the circulation, it could be in the kidneys with the actual nephron tissue, or it could be as urine's leaving, it doesn't have a way to get out, and so it just backs up into the kidneys, causing damage and hydronephrosis. Let's look at clinical manifestations of acute kidney injury. The patient will go through 3 stages, and if the patient does not move into the recovery stage, then they will progress to chronic kidney disease. If you look on page 1071, that's where we're starting. So some clinical manifestations start in the oliguric phase. So this is going to be the first phase that the patient may or may not go into. Like I said before, 50% of cases have no changes in urinary output. This makes diagnosis harder. So if your patient does not go into the oliguric phase, we still need to be looking at those lab values like creatinine in particular for acute kidney injury. So during the oliguric phase, if your patient is in this phase, it begins within 1 day of renal injury. Oliguria has a couple different definitions in the book. So let's start with these urinary changes marked by urine output. So urinary changes during the oliguric phase could include oliguria, obviously. Your book's definition throughout, that is going to be less than 400 mils per day or less than 30 mils per hour or less than 0.5 mils per kilogram per hour. So if your patient's urine output falls below any of these numbers, then they would be considered oliguric. Another term you may see is anuria. Anuria indicates that there is some sort of urinary tract obstruction, whether it's in the ureters, the bladder, or the urethra, and that would be usually due to post-renal causes. Anuria is less than 50 mils per day. And this is mostly associated with obstruction, which is post-renal. This is going to occur within 1 to 7 days of injury or within 24 hours of ischemia, like in pre-renal ischemia, or within 1 week if there are nephrotoxic drugs. With the urinalysis, I had mentioned that you will see something in particular with acute tubular necrosis, and that is something called a cast. So with a urinalysis, casts will be evident in the urine. Now, casts are mucoprotein impressions of necrotic renal tubular epithelial cells. and they slough off into the urine, and this indicates acute tubular necrosis. This will be apparent in intrarenal damage, that there is some sort of nephrotoxic process going on, some sort of injury to the epithelial cells that make up the nephron. It's a very delicate structure. They are single cell thick. Another indication that a patient may be in the oliguric phase is the specific gravity. So normally specific gravity is 1.003 to 1.030. So normal 1.003 to 1.030. Now in the oliguric phase, it's not that their specific gravity is abnormal. It's actually that it's fixed at the specific gravity of plasma. So this is letting you know that plasma is coming out unchanged from the kidneys. And this is one of the more difficult concepts to understand. The kidneys are losing their ability to concentrate the urine. So what's happening is plasma is leaking out into the filtrate, and it looks identical to what's in the blood. There's no discretion when it comes to the nephron in terms of pulling out electrolytes, pulling out water. It's just leaking this fluid from blood volume. That's the same case with specific gravity. With urine osmolality. So urine osmolality, normal is pretty wide range, and you'll see different numbers, but 300 to 1300 milliosmoles per kilogram. It's more accurate than specific gravity because osmolality measures concentration by weight rather than volume. So urine osmolality in the oliguric phase is also fixed at the plasma level, which is about 300 milliosmoles per kilogram. We may also see, like I had said previously, proteinuria, indicating that there's some sort of glomerular damage, allowing albumin and large plasma proteins to leak into the urine. Proteinuria is never normal. Now, if our patient is not peeing at all, they are retaining a lot of fluid. So fluid volume, they may be fluid overloaded. If they have decreased urine output, they're retaining all that volume. So decreased urine output equals fluid retention from RAS and ADH. And if you need a review of ADH, like I said, go to your index, find where that is. So you would see those signs and symptoms like jugular venous distension. You would see a bounding pulse. You would see edema, anasarca, which is generalized edema, hypertension, pulmonary embolism, pericardial and pleural effusions. Pulmonary edema, whenever I shorten it, pulmonary edema. Pericardial and pleural effusions. So fluid is leaking into those transcellular spaces like pericardial space, the pleural space, where fluid is normally in small quantities, and that fluid from overload is leaking into those spaces. Now, if your patient is in renal failure and they are hypovolemic, that can exacerbate the kidney injury. Because whether or not it's pre-renal, post-renal, intrarenal, there's some damage going on, and if we add hypovolemia to that, that's a cause for pre-renal damage, which can lead to further intrarenal damage. So it's important to monitor your patient's blood pressure, your patient's do your general assessment in terms of is there any signs of dehydration that need to be corrected, because then that can result in intrarenal damage. So referring back to when we talked about the functions of the kidneys, if we have problems with acid-base balance, what's going to happen is metabolic acidosis, where the pH is low, and in comparison, we have an excess of hydrogen ions to that of bicarb ions. What's happening is we have impaired kidneys, obviously, which leads to an inability to excrete hydrogen ions and acid byproducts because of defective reabsorption, regeneration, and buffering of hydrogen ions. We're not able to retain enough bicarb to match up the hydrogen ion ratio. Remember, that's 20 bicarb to 1 hydrogen ion. In effect, our lungs are going to try to compensate, so we may see a patient develop Kussmaul's respirations, which are deep, rapid respirations in order to blow off CO2. With regard to sodium balance, when we have damage to the tubules, that results in an inability to conserve sodium, which increases sodium excretion. So you may see, depending on what's happening with volume as well, normal to low sodium. So even though our RAS system is overactive, at this point, the kidneys are not actually responding to the hormones because there is a functional problem with the nephron itself. This is going to lead to dilutional hyponatremia, especially if we have a volume excess. So with sodium, we think neuro. And fluid balance as well, it's going to disrupt the actual water content inside the cells of your brain. So we may result in cerebral edema, which could progress to seizures and coma. Our patients, though, in acute kidney injury, they do need to avoid excess intake of sodium. So we want to keep it within normal limits, but we don't want to overload them with sodium because sodium has osmotic pull, and so it will cause volume expansion. And if your patient is already fluid volume overloaded, that's going to cause an exacerbation of hypertension and heart failure. Like I said at the beginning, your kidneys excrete 80 to 90% of potassium in your blood. Potassium is mainly found on the inside of the cells. One reason for this potassium excess is that the kidneys can't excrete all that potassium that they need to. So we have this impaired ability to excrete potassium. However, if we have acute kidney injury as a result of massive tissue trauma, whether it's bleeding, whether it's muscle breakdown, whether it's hemolysis from a blood transfusion, that is going to release potassium from the cells. So if this cell is broken up in trauma, that potassium leaves the ICF and moves into the ECF, in particular the intravascular space, which causes this potassium excess. Now, on the previous slide, we talked about metabolic acidosis. Getting my letters mixed up. So normally, like I said, we have a lot of potassium on the inside of the cell. However, when we have hydrogen ion excess, as in acidosis, hydrogen ions have this affinity to go inside the cell. And we know when that environment becomes too positive, potassium has to leave. So potassium is going to exit the cell when you have an excess of hydrogen ions entering the cell, causing hyperkalemia. So there are multiple reasons for why these patients develop hyperkalemia. Just a reminder, your signs and symptoms of potassium excess, weakness, and of course cardiac dysrhythmias like a peaked T wave. Your heart becomes too excitable, and so it's hard for that T wave to be normal because that represents ventricular repolarization, and it's hard for the heart to repolarize itself or go back to its resting state when it's hyperirritable, as in a potassium excess state. They may also develop a widened QRS complex, an ST segment depression, with hyperkalemia. Make sure you go over those signs and symptoms in chapter 16, I believe it is. That chapter should set you up nicely for understanding what you might see in your patient, because it's not always straightforward in that you get a number for your potassium. You also want to make sure that you understand the signs and symptoms. And symptoms of potassium excess are listed on page 280 to 282. So make sure you go through that in your med-surg book and you understand what that looks like. When we're talking about acute kidney injury, remember this is an acute problem. This develops over days or hours. So in terms of the hematologic disorders that result, because we know that our kidneys are responsible for erythropoiesis, but if we have multi-organ failure going on, we could have leukocytosis, especially if it's associated with sepsis or infection, like in acute interstitial nephritis. One thing to take away from this workshop especially is that the most common causes of death between AKI and CKD are very different. The most common cause of death in AKI is infection. This is for acute kidney injury. The most common cause of death is infection. So keep that in mind when you are thinking about prioritizing your patient care. In terms of waste product accumulation, and remember, we're still in the oliguric phase. Urea is going to build up, so that's blood urea nitrogen is going to be increased. Like I said, urea is an end product of protein metabolism, but BUN can also be elevated with dehydration, corticosteroid use, catabolism in infection, meaning increased breakdown of nutrients or a fever-like state. Any type of injury or trauma. Normally these byproducts are excreted in the kidneys. With creatinine, like I said, this is an end product of endogenous, meaning inside the body, protein or muscle metabolism. So it's relatively constant, and this is going to be the best serum indicator. According to your med-surg book, it is the best serum indicator of AKI because it's not significantly altered by any other factors. as these waste products build up, and as sodium becomes imbalanced and fluid becomes imbalanced, you may see neurologic disorders in your patient, which are a result of the accumulation of waste products, of nitrogenous waste products. So you may see confusion, changes in level of consciousness. Be very sensitive to neurologic status because that's going to tell you a lot about your patient's general status. Let's move to the diuretic phase. So as you can guess, this is when your patient is finally getting an increase in urinary output. According to your book, the urinary output can be up to 1 to 3 liters a day or greater than 5 liters per day if the nephrons are not fully functional. This could last 1 to 3 weeks. Basically what's happening is osmotic diuresis, meaning because of the osmotic gradient in the blood and the filtrate, we have a high urea concentration in the glomerular filtrate, and that has a high osmotic pull. The tubules in the nephron have a hard time concentrating urine, so we have osmotic diuresis from this high urea concentration in the filtrate, which basically pulls water out of the body, out of the intravascular space, compounded by the inability of the tubules to concentrate urine. This is going to result, as your patient is losing liters and liters of fluid in a day, we're obviously going to see hypotension, so decreased blood pressure, and hypovolemia. There are a risk of many electrolyte imbalances, particularly hyponatremia, hypokalemia. So look at that CMP regularly, making sure that all of your electrolytes are within normal range. And I can't emphasize enough going back and looking at those signs and symptoms in chapter 16. For the third phase, hopefully your patient will reach this phase if we've given them adequate medical care, if they're in a better clinical state. In the recovery phase, this is when we're obviously recovering. So an increase in GFR will become apparent because as your kidneys fail, the glomerular filtration rate, or the number of milliliters per minute that your kidneys are filtering, decreases as the kidneys are failing. As they recover, that's going to go up. We're going to see a decrease in those waste products, decreased bun and creatinine. Major improvements will be seen within 1 to 2 weeks, but it could take an entire year to stabilize. The patient will have potentially residual damage, and if they don't enter this recovery phase, that leads to chronic kidney disease, which will be our next subject. Make sure you go through your text and look at the diagnostic studies. We covered a lot of those when we talked about the pathophysiology. I am going to focus mostly on the pathophysiology for this test, just because there is so much to cover. I'll briefly go over interprofessional care, and this is going to depend on the phase of acute kidney injury. Remember, it could be the oliguric, the diuretic, or the recovery phase. So according to your book for interprofessional care for acute kidney injury, we have a few goals that we're trying to achieve. Our first goal is always prevention. Identifying patients who may be at risk or receiving those nephrotoxic drugs, patients who may be dehydrated, patients who could possibly have a urinary tract obstruction. In terms of treatment and management, Number one, we need to correct those fluid and electrolyte disturbances. We need to manage our patients' blood pressures. Treat infection, because remember, the primary cause of death in acute kidney injury is infection. So we need to treat those infections. The problem with that is if our patient does have an infection before the culture can be completed, because that takes a few days, we have to put them on those broad spectrum antibiotics, and those can be nephrotoxic. We need to maintain nutrition. And a huge key to this is remembering that drugs are not excreted. So when your patient has acute kidney injury, whatever medication that they have that they take is going to stay in their system longer. So treatment dosages may have to be adjusted. So communicating with the physician and understanding the recommended dosages, considering their glomerular filtration rate, need to be taken into account. So in order to correct our fluid and electrolyte balances, we need to determine if there's adequate intravascular volume and cardiac output to ensure renal perfusion. And like I said, hypovolemia can exacerbate acute kidney injury. For your patient, with correcting these disturbances, forcing fluids and diuretics can be harmful. So what they're going to do is closely monitor fluid intake, especially during the oliguric phase. Now, one key idea behind monitoring fluids is a fluid restriction. And typically with a fluid restriction in these patients, this is very important. It's going to be their output over 24 hours, the last 24 hours, plus 600 mils for insensible fluid loss, whether that's losing water through breathing, sweating. You're going to take their output for the last 24 hours and you're going to add 600 mils, and that would be the amount of fluid that they're allowed to have that day, because we don't want them to be in hypervolemia. So let's say your patient had an output of 1,000 mils the day before. You would add 600 to that and say the fluid restriction is 1,600 mils for the day. They cannot drink more than that. Diuretics may be used, so be familiar with your diuretics. Like I said, forcing fluids and diuretics, it could be harmful, but it's going to be necessary, especially with electrolyte disturbances like hyperkalemia. Furosemide or Lasix is one loop diuretic, and bumetanide is Bumex, it's another. Or osmotic diuretics may be used. If we aggressively diurese a patient with fluid volume overload, that could result in reduction in renal blood flow. So that restriction is going to be key in these patients. With other electrolyte disturbances, that's going to be hyperkalemia. So watch for hyperkalemia. It is a life-threatening electrolyte imbalance that can result in cardiac dysrhythmias. There are many different treatments for hyperkalemia, and very few of them actually get rid of the potassium from the body. In treating hyperkalemia, insulin can be given to shift the potassium back into the cells. That does not actually get rid of the potassium, it puts it back where it used to be. Another solution that does that is sodium bicarb. So sodium bicarb helps shift that potassium into the cell the way that insulin does. It does it more so by putting you in a state of alkalosis. With acidosis, we know potassium shifts out of the cell. Well, that's true in the opposite. With alkalosis, that potassium is going to move right back into the cell. However, these are transient, so they're only temporary. These are transient, and they shift potassium back into the cell. A drug that can be given is also calcium gluconate, and this is going to raise the threshold at which dysrhythmias occur. It's temporarily going to stabilize the myocardium. That's going to help prevent your patient from going into those dysrhythmias that can be life-threatening. But the only real ways to actually get potassium out of the body completely is with a drug called K-oxalate or with dialysis. So hyperkalemia, the only way to get it completely out, remove potassium from body. Those diuretics are going to help excrete it, like your loop diuretics, especially the potassium wasting ones like the loop diuretics. And then K-oxalate or sodium polystyrene, that removes potassium. It exchanges potassium for sodium in the gut, and so you essentially pass it through the feces. It's given PO, and so this is not something that's going to get rid of potassium right away, the way that dialysis would. It's going to help the patient get rid of it through the bowel, but we know that takes longer than something, say, IV like dialysis. One consideration with K-oxalate is that we have to give it, we cannot give it without bowel sounds, because if your patient has a paralytic ileus indicated by hypo or non-existent bowel sounds, that can cause bowel necrosis. So we need to make sure that your patient has bowel sounds before giving K-oxalate. The other way to get rid of potassium from the body completely is with dialysis, and we'll talk about the different types of renal replacement therapy. Renal replacement therapy is comprised of not only dialysis but kidney transplant. That is the umbrella term for basically replacing the kidneys. You can either do that with the different types of dialysis or a complete kidney transplant. With your patient, we also talked about managing blood pressure has to do with those drugs that we're giving them to control their BP within normal limits, controlling any hypertension from fluid volume overload, treating infection, like I said, potentially antibiotics, depending on if it's bacterial, viral, maintain nutrition. So in terms of nutrition for a patient in AKI, they should have a caloric intake of 30 to 35 kilocalories per kilogram of body weight, and their protein, considering that they may have nitrogenous waste products, will be about 0.8 to 1.0 grams of protein per kilogram of desired body weight. So if you turn to page 1073 and 1074, this is going to give you interprofessional care. Just be aware of those dietary recommendations under nutritional therapy. Being aware of which electrolytes are high in which foods, limiting sodium if necessary to prevent edema, hypertension, and heart failure. Know those foods high in sodium, like canned foods, deli meats, soups, canned soups. And then potassium regulation with the blood levels requires knowing which foods are high in potassium. Foods high in potassium in particular, potatoes are very high, white potatoes. Tomatoes are high, avocados, bananas, so be aware of those foods as well. Let's look at chronic kidney disease. So we're going to move from acute kidney injury to chronic kidney disease. For this one, let's use red. So CKD, this is going to start on page 1075. This chronic kidney disease is a progressive, irreversible loss of kidney function. Acute kidney injury, we talked about it being reversible. Chronic kidney disease is irreversible. Of course, there are lifestyle changes that we can encourage our patients to make in terms of disease states that cause this. But at this point, when someone's losing kidney function in this way, it's irreversible. Our most common causes of chronic kidney disease, number 1 is diabetes. Remember from level 2 learning about how persistently high blood sugar levels and insensitivity to insulin of the tissues, all of the pathophysiology behind diabetes results in nephropathy, which is a pathologic change in the nephron, which results in chronic kidney disease. Another common cause is hypertension. So diabetes and hypertension are the most common causes of chronic kidney disease. We have a diagnostic criteria to place a patient in this category. This is the presence of kidney damage or a GFR less than 60 mils per minute per 1.73 meters squared. This is the number you really need to look at, is GFR less than 60 for longer than 3 months. So this isn't something that just happens overnight. This is a progressive, irreversible loss of kidney function. Within that diagnostic criteria, end-stage renal disease is a GFR less than 15, requiring that renal replacement therapy I mentioned in the last slide. So that would be comprised of dialysis or transplant. Transplant really only occurs in 4% of patients with end-stage renal disease due to the lack of donors and the qualifications for kidney transplant. A lot of the clinical manifestations with chronic kidney disease are a result of the retained nitrogenous byproducts of metabolism, electrolytes, and water. Let's look at figure 46-2 in your MedSurg book. This is on page 1077. There's a figure of a woman, and it's pointing out multiple systems in her body to address each sign and symptom you would see in your patient. So review that figure. Your patient's going to experience uremia, which we talked about being that elevation in bun and creatinine with those signs and symptoms of fatigue, neuromuscular irritability, or neurologic symptoms, that is. Uremia is a syndrome in which renal function declines to the point that symptoms may develop in multiple body systems, like we talked about at the very beginning. And this is often going to occur with a GFR less than 15 mils per minute. When we look at the urinary system regarding clinical manifestations, there is little change in urine output unless it's related to the polyuria associated with diabetes. Remember those 3 P's of diabetes: polyuria, polyphagia, and polydipsia. The patient may experience fluid retention. And if the patient is on dialysis already, they may experience anuria because the dialyzer or the dialysis machine functions to pull off excess fluid from the patient so that the kidneys don't have to, mainly because they can't. Metabolic disturbances related to chronic kidney disease. We have waste product accumulation. With a decrease in GFR, there is an increase in bun and creatinine. Remember, there are multiple reasons for an increase in bun, but creatinine is pretty constant when it comes to endogenous muscle breakdown. The results of these being elevated are manifested as nausea, vomiting, fatigue, impaired thought processes, and headache. So these would be those symptoms as multiple body systems that you would see uremic complications in. We talked about how the kidneys are responsible for synthesizing glucose from amino acids. Well, if we have failing kidneys, we have altered carbohydrate metabolism that results from impaired glucose metabolism. With someone who has diabetes, they have a cellular insensitivity to insulin, which results in mild or moderate hyperglycemia and hyperinsulinemia. It may improve after the initiation of dialysis, but if the patient has uremia, that indicates their GFR may be low and less insulin may be required as they lose kidney function. Remember, because the kidneys are responsible for excreting drugs. Well, insulin is a drug, whether it's an exogenous source of a hormone that we give via subcutaneous injection. So if someone's uremic, they may require less insulin. So you would see hyperglycemia, decreased insulin need if the patient is uremic. That just means that the insulin remains in the circulation longer, so it's effective for longer periods of time. With hyperinsulinemia, like in diabetes type 2 in particular, that results in the hepatic production of triglycerides. So triglycerides are going to be elevated in the patient, which if someone has pre-existing atherosclerosis is going to cause complications in terms of blockages in the arteries. In terms of electrolyte and acid-base imbalances, with potassium, we know that becomes elevated because of decreased excretion by the kidneys, breakdown of cells if there's any cellular trauma, and metabolic acidosis. At levels around 7 to 8, that's when the patient may experience a fatal dysrhythmia, so we want to keep that potassium within 3.5 to 5. With sodium, and a lot of this does overlap with AKI, but I'll try to move through it as quickly as I can. Sodium is going to be restricted for these patients to 2 grams per day. Because our kidneys have impaired excretion of sodium and water may be retained, and it may appear to be a dilutional hyponatremia. But if we add sodium to that contributes to pulling water osmotically into the intravascular space and will contribute to edema, hypertension, and heart failure. So let's take a closer look at the relationship of calcium and phosphate with regard to electrical or electrolyte imbalances. This is demonstrated on page 1078 under musculoskeletal system, CKD mineral and bone disorder, or CKD-MBD, which is a systemic disorder of mineral and bone metabolism caused by progressive deterioration in kidney function. So there's a pathomap on page 1079, but before we go into that, I do want to talk a little bit about the physiology behind what happens with calcium and phosphate to make it clear why these electrolytes are inversely related. So 99% of calcium is stored in the bone, and the rest of it is stored in either plasma in the blood or in body cells. Half of the calcium in your plasma is bound to plasma proteins and circulates in that way. But the type that we talk about that has the most important physiologic functions are ionized calcium, and a bulk of that is found in the plasma as well. The functions of calcium, it's obviously makes up bones and teeth and combines with phosphate in that way. It also contributes to blood clotting and is required for certain hormones to be secreted, like parathyroid hormone, calcitonin. It's required for the function of cellular receptors in your body. It has quite a bit of functions in your body, including contraction of muscles and transmission of nerve impulses, which is primarily where you see the clinical manifestations. Phosphate is also found in the bone. 85% of your phosphate is in your bone, and you have smaller amounts inside and outside of your cell. In your serum, we talk about ionized phosphate, and that's that PO4 negative that we talk about. Phosphate functions to help with acid-base buffering. And what that means is that phosphate buffers that are found in the serum react with either acids or bases to form compounds that change your pH. So they're important in acid-base regulation. They're also important in terms of energy and muscle contraction. So we learned in A&P all about adenosine triphosphate being the major molecule we associate with energy. Between calcium and phosphate, they're fairly rigidly controlled. They are inversely related in that if your calcium increases, your phosphate usually decreases, and vice versa. They're regulated by multiple hormones. So one of the big ones we're going to talk about is parathyroid hormone, which is abbreviated as PTH. And this is stimulated when calcium is low. So when we have low calcium in our blood, what happens is PTH is released from our parathyroid hormone, and it comes out of the bone. Parathyroid hormone breaks down bone in order to allow free or ionized calcium into the blood for all of those main physiologic functions we talked about. However, it also has an effect we don't really talk about very often, and this is where it becomes significant in kidney disease. What happens is parathyroid hormone, it encourages the reabsorption of calcium, ionized calcium, in the kidneys, in the nephrons. But not only that, it also encourages the excretion of phosphate from the filtrate so that it's excreted in the urine. So the net result in a low calcium level is not only is the parathyroid breaking down bone, which releases both calcium and phosphate, but the kidneys are told, reabsorb calcium, we don't actually want this phosphate, so the kidneys excrete phosphate. And this is essential to understand in this CKD musculoskeletal disorder. Another hormone that is closely related to the parathyroid hormone and calcium is vitamin D. And vitamin D, or cholecalciferol, is a fat-soluble vitamin that's usually ingested by food but can also be synthesized in the skin when you're exposed to UV light. The first step in activating vitamin D is in the liver, but the final activation is in the kidneys. So you can see how this is related to kidney disease. This is going to start when serum calcium levels are low. So your kidneys will start trying to activate vitamin D when your serum calcium levels are low, which that in itself stimulates parathyroid hormone secretion. Also, if we have a low phosphate level, that's going to stimulate vitamin D to be activated into calcitriol, which is activated vitamin D. So that activated vitamin D is going to help you reabsorb calcium from the gut, so that we can get more calcium into our serum, into our plasma levels. So when we talk about kidney failure and we're talking about electrolyte disturbances and bone demineralization, let's look at that pathophysiology map. So if we have renal failure, that means we have a low glomerular filtration rate. Well, that also means that we have decreased activation of vitamin D, because regardless of how much calcium is in our blood or how much parathyroid hormone is secreted, all of which contribute to the activation of vitamin D in the kidneys, our kidneys aren't working. So that causes impaired calcium absorption from the gut, from the small intestines. That's going to cause a further decrease in serum calcium. And then that causes an increase in parathyroid hormone. We know that's a stimulus for to increase our calcium levels. And if our kidneys aren't working, that's the parathyroid hormone is responsible for secreting that hormone in order to increase our calcium levels. So that's going to result in bone demineralization, which should result in an increase in serum calcium levels. And it also does increase your serum phosphate levels. But remember what I said about parathyroid hormone, that it then tells your kidneys to excrete phosphate. As a result, we have vascular and soft tissue calcifications as these precipitates form. So even though we have an increase in serum PO4, our kidneys aren't listening to parathyroid hormone. This isn't necessarily a result of parathyroid hormone. This is a result of our decreased GFR. This is going to decrease my PO4 excretion. So not only do I have my bones being broken down to release calcium and phosphate, but I don't have my kidneys eliminating the phosphate that comes with it, because if that phosphate's not eliminated, I get these calcifications in my body. So that actually results in an increased PO4 level, which is going to contribute to these calcifications. So if you're following this pathophysiology map on page 1079, you see here it says we have osteitis fibrosa, and this is going to occur as parathyroid hormone breaks down this bone, and what happens is it's replaced with fibrous tissue. But we also have osteomalacia, which according to your book results from demineralization from slow bone turnover and defective mineralization of newly formed bone. So we have two problems with our bones in kidney disease. And that's a direct result of the loss of kidney function in terms of being able to excrete phosphate after parathyroid hormone has been released and has broken down bone, and also not being able to activate vitamin D and to absorb that calcium from the gut. So returning back to the other electrolytes that are affected, we also have magnesium that may be affected. And this is going to be a complication if patients are ingesting a lot of milk, magnesium citrate, antacids. That would that would result in increased magnesium levels or hypermagnesemia, which would result in decreased tendon reflexes. Remember, it's mellomaggy, so it mellows you out. Magnesium is necessary to modulate muscle contraction at the myoneural junction, so where nerves meet muscles, and it tends to mellow the contraction out. It also causes a decrease in level of consciousness. It could cause dysrhythmias, hypotension, which if you already have pre-existing kidney disease, that could lead to further injury, because we know those pre-renal causes of AKI. And then we could also develop respiratory failure with paralysis of the diaphragm. One complication in terms of fluid and electrolyte balance as well is metabolic acidosis. And we talked about that with acute kidney injury. This results from an impaired ability to excrete excess acid and defective reabsorption and regeneration of bicarbonate to buffer that acid. So remember that ratio, we have to maintain that ratio. So we don't have enough bicarb to balance out those that pH, those hydrogen ions. Not only that, but a lot of protein in our body helps us buffer acids and bases to neutralize them. And if we develop metabolic acidosis, that also causes problems in our ionized calcium levels. Calcium, like I said, binds to protein in the body and circulates. That's 50% of the calcium in our plasma. But if we have an excess of hydrogen ions and acidosis, that influences or inhibits the binding of calcium to protein. And so that results in an increased ionized calcium level, which means that we have an excess of calcium with acidosis. And it's the opposite in alkalosis. So not only does pH affect potassium levels, but it also affects calcium levels as well. In terms of the hematologic system, now we didn't really talk too much about anemia in acute kidney injury, and that's primarily because our red blood cells typically live 90 to 120 days. Now, we said that chronic kidney disease is a decrease in GFR in end stage less than 15 for greater than 3 months, and for chronic kidney disease in general. So this is about 3 to 4 months that your red blood cells typically live. The problems start occurring about 3 to 4 months into kidney disease because our kidneys are not producing EPO, or erythropoietin, that stimulates our red bone marrow to produce red blood cells. So if we already have some red blood cells living in our body and transmitting oxygen and CO2, well, they'll be okay for about 3 to 4 months, but the dysfunction with erythropoietin may be manifested after that. Or if we have patients who have active blood loss, then obviously that would be a problem because normally erythropoietin would be stimulated. So our patients may suffer from anemia with a low hemoglobin, a low hematocrit. Bleeding tendencies are also a problem in renal failure. Typically, our platelets function in a normal body and aggregate adequately with the inflammatory response. But with the kidneys, it causes a qualitative defect in the platelet function when we have renal failure, and that's going to cause impaired clotting. So our patients in their hematologic system have anemia. They have bleeding tendencies because of the effect that renal failure has on the platelets. A lot of these complications can be corrected with dialysis, hemodialysis, peritoneal dialysis. But not only that, we have a predisposition for infection with renal failure because we have those same qualitative dysfunctions with renal failure, in our white blood cells, in our immune function. Our kidneys affect every system in our body. So we need to be on the lookout as nurses for these complications in our patients. Moving on to the integumentary system, with calcium and phosphate deposition in the skin, with the buildup of metabolic waste products, we have something called refractory pruritus, so itching. That's related to dry skin, it's related to those precipitates, it's related to neuropathy, especially if you have patients with diabetes. There's also something called uremic frost, which is associated with very late stage renal failure. This is where urea crystallizes on the skin and is usually associated when blood urea nitrogen exceeds 200 milligrams per deciliter. With regard to the reproductive system, there tends to be infertility, decreased libido, which is exacerbated by anemia. So not enough energy, not enough oxygenation. That would reduce a person's libido in terms of like the energy expenditure sexual activity would require. With women, there tends to be a decrease in estrogen, progesterone, and luteinizing hormone, which results in menstrual changes like amenorrhea, which these may return after dialysis. With men, it's a similar finding. They have decreased testosterone, decreased sex hormones, decreased sperm count, but these may return after dialysis. In terms of the peripheral neuropathy associated with diabetes, it could affect the reproductive system in terms of impotence or anorgasmy, in that the patient would not be able to achieve orgasm due to decreased nervous sensitivity. Mood changes occur as well. Personality, behavioral changes, withdrawal, depression, changes in body image, especially if your patient's undergoing dialysis. So your book goes into some diagnostic studies. That's listed on page 1079, and then interprofessional care is continued through there. Again, I focused a little bit more on the pathophysiology. A lot of this overlaps with acute kidney injury in terms of the treatment for hyperkalemia. You want to know your foods high in potassium, high in sodium, high in magnesium, all those electrolytes that they may be restricted. One thing to consider as opposed to AKI, the primary cause of death in chronic kidney disease is a cardiovascular event. So cardiovascular disease, whether it's MI, peripheral artery disease, heart failure, cardiomyopathy, stroke. These are going to be complications associated with chronic kidney disease, as opposed to AKI, the primary cause of death is infection. So your book goes into many different ways of treating the complications. I would encourage you to read through that. Let's look particularly at dialysis. So we talked about renal replacement therapy, and renal replacement therapy consists of both dialysis and kidney transplant. And there are different types of dialysis. Dialysis is essentially the movement of fluids and molecules across a semi-permeable membrane from one compartment to another. It's a technique in which substances move from the blood through a semi-permeable membrane and into a dialysis solution called dialysate. It's used to correct fluid and electrolyte imbalances and remove waste products in kidney failure. And can treat drug overdoses as well because it's able to diffuse all of those toxic substances out of the blood. So one type of dialysis is peritoneal dialysis, or PD. This is where the peritoneal membrane, or the membrane surrounding the digestive organs, acts as a semi-permeable membrane. As opposed to hemodialysis, or HD, which uses an artificial membrane. And it is used as a semi-permeable membrane which is in contact with the patient's blood. So these types of dialysis are indicated for various reasons. It's usually when a patient's uremia can no longer be treated with conservative medical management or when GFR is less than 15. With uremic complications, you may see encephalopathy, neuropathies, uncontrolled hyperkalemia. Remember we said dialysis is one of the only ways to get the potassium out of the blood. Uremic pericarditis, where urea builds up and irritates and inflames the pericardial membrane, and accelerated hypertension as well can indicate dialysis. General principles of dialysis. Include diffusion. So if you are unfamiliar with diffusion, that's where we have some solutes on this side, a lot more solutes on this side, because we have a high osmotic pull on this side here. Water on this side here, osmotic pull is greater. Water is going to move this way, that's osmosis. And with diffusion, these solutes are going to move to try to balance out this side. So solutes move from the right side to the left side, and water moves from the left side to the right side. If it has a less solute concentration to a higher solute concentration on the right side, the solutes move to the left, and the water moves to the right. So that's your principles of osmosis and diffusion. I know I kind of flew through that, so review chapter 16 if you are unfamiliar with it, but that's the principle. Those are two principles that dialysis uses to get rid of excess fluid and electrolytes. Ultrafiltration is a term that's used with dialysis. Ultrafiltration is where you have water and fluid removal. It results with an osmotic or pressure gradient. In peritoneal dialysis, this uses an osmotic gradient. In hemodialysis, that uses a pressure gradient. So hemodialysis usually requires a fistula where, let's say this is a vein, this is an artery, so here's V for vein, A for artery on this right side. They're anastomosed, which means that they're connected to increase the pressure so that you can force pressure to occur in the dialyzer, and you would have ultrafiltration of water and removal of those substances that you don't want in the blood. We'll talk about, let's look at page 1087. Be familiar with your arteriovenous fistulas and grafts under your vascular access sites. You want to know what is normal for a fistula or graft. You can also see on page 1088 There are temporary vascular access devices that you should review and read through. Procedure for hemodialysis on page 1089 to 1090. We don't have enough time to go over everything, but be sure to read through the rest of that chapter. Let's move on to liver, and I'm going to start a separate recording for that in case you need to pick back up later. Thank you and have a good day.